Now, just recently, the American Association of Clinical Endocrinology released their 2025 updates on obesity care. In this consensus statement and algorithm, ACE redefine how we should evaluate and treat adults with obesity and adiposity-based chronic disease. So let's take a closer look at what this update contains and why the consensus was needed to guide more effective patient-centered management. So let me just give you the background of this presentation. Over the years, our understanding of obesity has evolved significantly. It is now recognized not simply as excess weight, but as a chronic disease with a complex biological drivers and systemic consequences. Now, this shift has led to a move away from weight-centric care towards a complication-centric model, where treatment is guided by the presence and severity of health complications rather than BMI alone. In 2017, the American Association of Clinical Endocrinologists, or AACE, introduced the adiposity-based chronic disease, or the ABCD framework, which reframes obesity through the lens of pathophysiology and clinical impact. Now, this framework was further refined and updated in 2025, reinforcing the need for personalized, evidence-based care that addresses the full spectrum of obesity-related conditions. Now, obesity guidelines have evolved over 3 decades, from the initial ACE statement in 1990s recognizing obesity as a chronic disease through the 2014 framework expanding diagnosis beyond BMI to the latest 2025 ACE consensus statement and algorithm, which provides an updated patient-centered approach to evaluation and treatment of adiposity-based chronic disease. So, let me walk you to the historical evolution of obesity guidelines. The journey of obesity care began in 1997 when the American Association of Clinical Endocrinologists, or ACE, released its first consensus statement. This was followed by an update in 1998, 2012, and 2014, with the 2014 statement making a milestone in that obesity was formally recognized as a chronic disease. In 2016, ACE advanced the field with a comprehensive guideline and algorithm. This was the first evidence-based complication-centric approach, shifting focus away from BMI alone. Instead, treatment intensity was matched to the severity of complication, and obesity was staged based on risk and clinical impact. By 2017, ACE introduced the diagnostic term adiposity-based chronic disease, or ABCD, emphasizing the underlying pathophysiology and complications that drive morbidity and mortality. In 2019, the European Association for Study of Obesity endorsed ABCD, aligning with international efforts to move beyond BMI in diagnostic criteria. Meanwhile, the Lancet Commission on Obesity refined definition further, with number 1 preclinical obesity as an excess adiposity without complication, and number 2 clinical obesity in which excess adiposity with organ dysfunction or symptoms. Together, these milestones shape today's understanding. The ABCD serve as an umbrella term covering prevention, preclinical obesity, clinical obesity, and obesity-related complications and diseases. The evolution reflects a shift from weight-based definition to a comprehensive, complication-centric model of chronic care. So the question is, why the updates? Now, these updates reflects a major shift in how we approach obesity care. First, it integrates the latest evidence on cardiometabolic risk, inflammation, and organ dysfunction, recognizing obesity as a condition that affects multiple systems, not just weight. Second, it emphasizes the importance of personalized care and shared decision making, tailoring treatment to each individual's need and values. And third, it directly tackles stigma by reframing obesity as a complex chronic disease, moving away from stigmatizing assumptions and towards compassionate, evidence based management. Now, before we turn to the latest AACE consensus statement, it's essential to first examine the foundation reframing offered by the Lancet Diabetes and Endocrinology Commission 2025, and this commission proposed a clinically grounded definition of obesity, not merely as excess weight but as a disease distinguished by its impact on organ function and overall health. It introduced two-tiered model: preclinical obesity, where excess adiposity exists without current complications; clinical obesity, where adiposity has already led to measurable dysfunctions or symptoms. Now, this framework emphasizes that obesity should be diagnosed not by BMI alone, but by presence of biological alterations and clinical manifestations, providing a more precise and medically meaningful basis for care. With this in mind, we now turn to the 2025 ACE consensus statement and algorithm, which build on this paradigm to offer a structured, patient-centered approach for evaluating and treating adults with obesity and adiposity-based chronic disease. Now, this diagram illustrates the updated ACE framework for understanding obesity as an adiposity-based chronic disease. On your left, we see the causes of adipose tissue expansion, ranging from genetic and environmental factors to behavioral, psychological, and iatrogenic influences. These contribute to the development of obesity across a spectrum. The central section breaks obesity into three progressive stages. 1. Preclinical obesity, where there are no complications and quality of life is preserved. This corresponds to ACE stage 1. Number 2, clinical obesity, which involves symptoms and organ involvement, classified as stage 2 or 3 in ACE consensus. And finally, obesity-related disease such as type 2 diabetes, cancer, and MAS, representing advanced complication. At the bottom, we see the prevention strategies aligned with each stage. Primordial and primary prevention aim to stop obesity before it starts. Secondary prevention focuses on reducing risk in clinical obesity, and tertiary prevention is complication-centric, targeting disease management and quality of life. This model reframes obesity not just as excess weight, but as a chronic progressive condition requiring personalized, stage-based care. Now, after understanding the ABC framework, the ACE 2025 update translate it into 9 practical algorithms that guide clinicians step by step. We begin with algorithm 1, which sets the foundation principles of person-centered and complication-centric care. Algorithm 1, the ABCD care, emphasizes whole person health, combining empathic diagnosis, individualized treatment, and long-term follow-up to improve complications and quality of life. Algorithm 2 on your right, the ABCD diagnosis, combine anthropometric measures and clinical evaluation to confirm excess adiposity and assess obesity-related complication, guiding personalized stage-based care. Now, algorithm 3 on your left is the anthropometric diagnosis confirms excess adiposity using BMI, waist, metrics, and body composition interpreted with ethnic specific criteria to assess cardiometabolic risk. While algorithm 4 on your right, clinical diagnosis of ABCD involves staging disease severity based on obesity-related complication, screening for secondary causes, and integrating psychological and social factors into individual care. Okay, so algorithm 5 on your left personalizes ABCD care by staging disease severity, tailoring treatment to goals and preferences, and ensuring long-term follow-up to sustain health outcomes. Algorithm 6 on your right defines weight loss targets by condition, guiding therapy adjustments based on response. For example, less than 5% loss of weight loss signals inadequate response or need intensified treatment. 5 to 10% weight loss is good for cardiometabolic risk. 15 and above is ideal for type 2 DM, MAS, and obstructive sleep apnea. So treatment is re-evaluated or maintained to meet clinical goals. Algorithm 7 on your left, behavioral lifestyle therapy for ABCD focuses on improving overall health through personalized nutrition, physical activity, sleep quality, and behavioral support, all shaped by social determinants and patient preferences. Algorithm 8 on your right, preferred medications for ABCD are ranked by complication type with tirzepatide and semaglutide leading across cardiometabolic and biochemical domains to guide personalized evidence-based care. So when specific medication aren't indicated for serious complication, we turn to algorithm 9, lower cost pharmacologic step therapy, a cost-conscious approach tailored to ABCD states and treatment response. So for states 1 and 2 ABCD, the recommendation is to consider first generation obesity medication like pentermine or a combination of pentermine topiramate if it's available, or liraglutide aiming for 5 to 15% weight reduction. In stage 3, where complications are more severe, the recommendation is strongly recommended to use second generation agent like semaglutide or tirzepatide, which offer 15 or more percent weight reduction. However, first generation option may still be trialed depending on cost and coverage. If the patient has indication for specific medication that targets serious complication, it is recommended shift to algorithm 8, the hierarchy preferred medication. Once therapy begins, we assess response. Now, a good or excellent response means clinical goal unmet, and we may taper or maintain therapy cost effectively. But if response is insufficient, the recommendation is to intensify lifestyle intervention and adjust medication, either switching agents or escalating to a more effective option if accessible. Now, this stepwise strategy ensures that treatment remain effective, affordable, and aligned with the patient clinical needs and resources. So this slide somehow summarizes all the 9 algorithms and presents a structured roadmap for managing adiposity-based chronic disease, or the ABCD, using 9 interconnected algorithms. These span the full clinical journey from screening and diagnosis, that's algorithm 2 and 4, to treatment planning and response monitoring, algorithm 5 and 6, lifestyle and pharmacologic intervention, algorithm 7 and 9, all grounded in a person-centered complication-driven care, which is algorithm 1. Together, they enable personalized, evidence-based, and stigma-free management of obesity and its complications. So what does this mean clinically? These implications represent a major shift in how we approach obesity care. We move past BMI alone, adopting a stage-based complication-focused model that captures the real burden of disease. This approach improves outcomes by matching therapies to specific complication while reducing stigma by centering on health rather than weight. It also reinforces the need for lifelong personalized management, treating ABCD as a chronic condition much like diabetes or hypertension. This is a new direction of obesity care, precise, compassionate, and sustainable. Now the conclusion. Now this is already the future of obesity care. The ABCD reframes obesity care not as a number on the scale, but as a chronic disease shaped by complication, context, and care. The 2025 algorithms give us a comprehensive, evidence-based roadmap guiding diagnosis, treatment, and follow-up with precision and empathy. And the ultimate goal is clear: to deliver personalized, stigma-free, complication-focused care where every patient is truly seen, heard, and healed. And with that, I bring this presentation to a close.